So before I begin, I just want to mention I do have a conflict of interest with RIVANNA. I've been helping them pro bono for a while with the device and giving them input, but I am receiving an honorarium for this talk today, and also that I've received gift funding where they've contributed towards our research effort at Stanford. All right, now that you've all gathered, I want a few of you to come close to the front row so I can actually start speaking. There's a few in the back if you want. All right, so a show of hands, who uses ultrasound to detect the neuraxial space? Okay, so maybe like a quarter to a third. So there's a lot of advantages, and particularly in a population that has difficult anatomy, understanding midline and giving a depth estimation is very useful. Meta-analysis data indicates that your accuracy is within 0.8 centimeters or 8 millimeters in depth accuracy. So knowing what equipment, when you get loss resistance, and knowing midline is extremely helpful to helping you, maybe not in the easy epidurals, but certainly in the more difficult ones. And the meta-analysis data pulled together shows technical improvements. So you can actually halve your technical failures. That's when you don't get CSF with a spinal or you don't locate your epidural space. You can significantly reduce your number of needle attempts, both redirects as well as initial passes, and you decrease your needling time, be it a little at the cost of an increased setup time. And there is data which is surprising, and I'll try and estimate why this actually happens, but you get better subsequent functioning of your epidural if you use pre-procedure ultrasound to place it. So why is that? A very clever study actually deliberately chose a L1-2 versus a L4-5 insertion point. And what do they find? They found if you put it in L1-2, it works great for first stage labor, actually sets up even quicker, but it doesn't work very well for second stage labor. And we've often seen that where we put the block too high. So this may explain the data suggesting you get better subsequent functioning. We had a theory that you're more likely to place it in the midline, it will work better, and we studied this, but we were not able to show this effect given the limitations of that study. In terms of decreasing traumatic punctures, there's actually data suggests a significant risk reduction, so 0.27. If you pull meta-analysis data that's not obstetric specific, a trend towards less backache, probably because of less needle passes, and we are not quite yet at the point of decreasing dural punctures, but knowing when you're going to get loss resistance may, if we have enough patients, show that benefit. There is also not enough data showing outcome differences in neurological injury. But when we use traditional landmarks, we are wrong 2/3 of the time. And we tend to be 1 or 2 interspaces higher than we think we are. So we naturally are going way too high. And given the variation of where the spinal cord ends, this can be potentially problematic. And given that we do less insertions with ultrasound, this could improve safety. Now, a lot of the studies are based on normal weight individuals, but we don't really care that much about it. We really care about the difficult patients. And it's estimated that about, on average, 44% of your neuraxial blocks are in the category of difficult, be it because of the patient or just because you struggle to get the block in. And if you have more difficult placements, the complication rate goes up, both with inadvertent dural puncture. One study showed for each centimeter deeper you go, the increased risk of 19%. So the deeper, the more difficult, and potential neurological complications. So the best study today is out of Toronto looking at this high-risk population, but it was not obstetric-based. So we're randomized to anyone who had the triad of terrible, so back issues, obesity, or previous surgery, scoliosis, were put into randomized to utilize a ultrasound-based technique versus a palpation technique. And you found significant reduction, almost halving the number of redirects, doubling the first pass success, decreased spinal time. This is a high-risk population. You can see the number of needle passes, 6 versus 13, and big interquartile range. So the difficult blocks, it can start really showing a significant benefit. Well, what data do we have in OB? So there are 3 studies, one involving labor epidural analgesia by Grau and colleagues, and this is, again, in patients with the obesity, a history of difficult placement, and lumbar spinal deformities. And they found significantly reduced needle insertion attempts and fewer failures with catheter advancements. For spinal anesthesia for cesarean, in patients that have a BMI greater than 30, randomized to either a ultrasound or a traditional-based technique, again, found the same theme: less passes, fewer needle attempts, and higher first pass success. And in a really interesting study, they didn't focus on BMI, because BMI is often a bad predictor to field blocks. It really depends on where the adipose tissue lies. In cases where they felt they couldn't feel bony landmarks, they were then randomized into ultrasound and no ultrasound, and again found the same theme of improved ability to get the block in. So with all these benefits, why are there so few show of hands of people who are utilizing the technique, or why do we run away from this technique? Some of it has to do with equipment, cost and complexity of utilizing this. Even at Stanford, there's our fancy schmancy machine. We have little labels to where to push and what to turn on. But the good thing about OB is we all have these ultrasound machines because they're using it to determine how well the fetus is doing. So we have the equipment, so it really becomes the ability to do it, the expertise. And it's actually a relatively simple technique you can learn easily with online videos and just trying it in a number of patients. The learning curve is very steep and easy to attain. And what you do is you scan up with a parasagittal oblique view, and then you flip the probe 90 degrees, you get what's called an equal sign or a bat's ears. You mark out the depth, and then you mark off where it is. It's a pre-procedure. They clean off the back, and you trust they don't move. If there's a little bit of movement, your alignment, your midline will always be accurate, but you may move the space a little bit. So it's a little bit complicated, a little bit of complex. So that's why this potential device, the Accuro, can actually fill that niche of making it a lot simpler device. So essentially, it's a handheld device, easily hold in your hand, gets quite good form factors, and it's designed specifically and only for neuraxial bony applications. It is not a device that you can use for looking, let's say, for IV access. And what makes this unique is that it has a software overlay, so it's doing the pattern recognition for you and calculating the depth automatically. It also has a 3D navigator that will show you where to go. And I'll sort of try and walk you through that briefly. So this is the overlay showing this is your epidural space. It's at 3.9. The spinous process was at 1.8. And this is the 3D navigator, and when that line is red, it's showing you you've hit midline. It can guide you as you go. It's simple to use. You just turn it on. You basically press neuraxial, and then you start scanning from the gluteal cleft up. As you see each image appear, you can automatically count the spaces, and you slide off the locator, and it indents the skin, so no skin markings required. Again, another image. So you're starting off. You're on spinous process there, so that's at 2 centimeters, the 2.1 centimeters. You keep sliding up until you get this nice image showing the midline. If you're off-center, then it'll guide you. You can see the off-center, the line is white, and you can just move it looking at that image. So it can actually guide you if there's scoliosis or some rotation. So last image, so there it is. You start scanning up. You get to your image overlay when you decide this is the space you want. You slide off the locator, indent the skin, and you can see, I don't know if you can see in the back, but it indents your skin. And it stays on long enough for you to, even if you clean it off, it doesn't get washed off, and you can go ahead and do it. All right, so does it work? So I don't know if Mohammed Tarun's in the room. He was the first to look at this. This was in volunteers, where they looked at the Accuro, looking at how good was it to detect epidural space compared to a ultrasound machine read by a radiologist, and it was pretty good, very high sensitivity and specificity. They also looked whether or not it could detect the spinous process, again, very high sensitivity and specificity, and also midline detection. So this was extremely encouraging results. And given this, we decided to try it out at Stanford. So Katie Seligman, I don't know if she's at SOAP, I'm not sure if she's in the audience. This was her project. She did all the scanning, which is important because she was an expert in it, and we wanted consistency, but it also potentially limits generalizability, but I'll discuss that further in a little while. We showed that we were able to, so we marked it off, and then the residents who were doing the block later had no idea what the depth was, and then we could compare them in a blinded fashion. The difference was minus 0.61. So remember I showed you that ultrasound is 0 to 0.8 centimeters, so it was in that same range of traditional ultrasound. And the good thing, it's minus, so it's going to tell you a little bit before you're going to get loss resistance. So that gives you a little bit of a safety margin. High degree of correlation. And we did not have a lot of obese patients, only about a third, and a handful with BMIs greater than 40. But you can see the mean bias on the Blant-Altman plot stays consistent throughout. Very high first pass success. An extension of the study, we then compared it to our fancy schmancy GE machine, and we found that they were very similar. The GE was slightly better, 0.29, so 0.3. This is limits of agreement, but for the depth differences, I showed you the 0.6 versus 0.3. So in the same ballpark, but slightly more accurate, the GE, but nevertheless within that range that's been described within the centimeter range. And both were very good at presenting horizontal and vertical deviation. So I mentioned, do you really need to be an expert? This is an Italian study in pregnant volunteers. 96 patients allowed an expert ultrasonographer to utilize Accuro versus a novice, and they found no difference. In other words, anyone can really do it. The learning curve is extremely short. And in the same study, they compared it to a traditional ultrasound. They had two different laptop ultrasound machines and found it worked very well. A little bit more of a scatter, but the mean bias difference was very, very small. And then very recently, hot off the press was this study. A large group, 150 residents predominantly doing it. So it's a practice that a lot of academic centers work in. And if you look at first pass success with the Accuro versus palpation, needle insertions, passes, and time for procedure, there was actually no statistical difference in these. But if you drill down a little further on their data and broke it up into women who were BMI greater than 30 versus less than 30, you started showing the difference of needle insertion, needle pass reductions, as well as less really difficult spinals defined as more than 10 attempts. So you can see the same pattern emerging that I showed you with the ultrasound-based that you see with Accuro, which is it starts to become clearly more useful in patients where they have difficult anatomy to detect. So that's all, because we're going to trying to have time for questions, so I rushed through that. And Peter's going to come and talk to you about his study, which he did and was presented at ASA, and he's going to give you more details about his experience in a slightly bigger population that he has at Wake Forest. And I thank you for your time.